Good morning. Thank you all for being here. It's such an honor to be around such amazing thought leaders in navigation. I feel like it's such a tremendous gift to be here. So my name is Cynthia Cantrell, and I was actually recruited to our healthcare system about 7 years ago. So to keep in mind that we're an emerging healthcare system in the sense that Sutter Health actually incorporated all of Northern California, 22 counties. So we serve about a population area of 12 million people. 3.5 million are in our healthcare system. So this morning, I want to share with you the variation in nurse navigation practice we see within Sutter Health, an experience of navigators, what areas they're providing care in, how patients want their navigator to function, and actually the impact. And I was telling Nick, I'm a little nervous this morning after his presentation yesterday, because even though I'm not a numbers person, I've been forced to really love data in a way that I never thought that I would appreciate data heretofore. I was telling Dr. Schulman, we had a tremendous impact. I learned far great the impact of navigation in the sense of our fires recently. I am in Sonoma County, which is right here. I'm about an hour and a half, 2 hours north of the Golden Gate Bridge. The fires impacted this entire area here. We displaced just immediately around our infusion center 90,000 people. We lost 1,000 homes. 1 out of every 6 of our physicians lost their homes. So I was faced very quickly at the command center of navigating our patients on current infusions to try to actually bridge that gap. Some of our patients were driving 500 miles a day for their chemotherapy infusions. I say that because I think it gave me a sense of the power of the networking that navigators have. It was remarkable to me to pick up the phone to a nurse that literally was in downtown San Francisco and say, "Don't worry, Cindy, we can get her in tomorrow." So that was incredibly important to me, and looking at kind of the hub and the spoke, if you will, of what the navigation model truly should be. When I took the position 7 years ago in Sonoma County, we actually had no medical oncology. And we've evolved that program to be a medical oncology practice. We finished our NAPBC. We expanded and moved into a new imaging center. We finished our hospital 2 years ago. So we've been able to really do a lot with our program in a very short period of time. And Nina will be happy to know we're having our first site visit for the COC next year. So it's been a rapid fire initiative. But we wanted to really look at offering comprehensive and integrated care using nurse navigation throughout the entire cancer care trajectory. We want to offer meaningful and affordable psychosocial support to patients during this time. And actually, in our practice, I have a philanthropically endowed program where we have peer support volunteers. I don't use the word necessarily in our model as lay navigators. We have unpaid peer volunteers. They go through an 8-hour training. We have monthly meetings. One of the cute things was when we started the program, the women decided to call themselves wings, women inspiring, nurturing, giving and supporting one another. And the men said, "Well, Cindy, we want to be a part of this program too." So they call themselves the wing men. So I can match a newly diagnosed prostate patient with a veteran prostate patient. Also within Sutter, we wanted to craft a template using establishing exemplary, replicable standards and metrics with applicability to the entire Sutter healthcare system, thereby decreasing variation in practice and preventing and reducing outmigration. So what happens without nurse navigators? I think it's very clear in the literature, and every time I pick up even the recent article with Dr. Schneider's work in navigation and diagnostic areas. It's so exciting for me to look at the explosion, if you will, in the literature of how we're really validating the benefit of navigation. And I won't go through all of these things, but I think as Dr. Freeman talked about yesterday, I think there's such, at least in our population, with a tremendous immigrant population in the San Francisco Bay Area, there's indeed a lack of trust. And I think there's also the anxiety associated with this cancer diagnosis and limited resources. So people have asked me, why are you so focused initially on breast cancer? And it's not that I wanted to focus exclusively on breast cancer. I felt that we weren't doing the best job we could do. I felt like if we couldn't enter the navigation at the time of a suspicious finding, then how difficult was it going to be to look at our patients with ovarian cancer, our young patients with lung cancer, or pancreatic cancer? So if we can't fix this in our system, then I don't know how we're going to be able to replicate what our ideal state should be. So we started off with breast cancer initially. Actually, I was happy that I submitted what's called the President's Grant, and 50,000 of our employees were able to vote. I did come in second place underneath adolescent help, but at least I trumped sepsis because I thought, we're going to do a grant for sepsis. We should all be doing sepsis care. But we diagnosed 3,000 new breast cancer cases per year in our system. And I would love to do a research study on the impact, or kind of looking at the distress associated with breast cancer as opposed to other types of cancer, in the sense that I think that I don't have any scientific validation for this, but I look at our other patients that have some sort of sense something's wrong. They've got night sweats, lump, bump, cough, bleeding, something. Our breast patients come in and they say to me every day, oh, Cindy, nothing's going to be wrong. I do yoga, I eat organic, I do all my great health things, and sure enough, they are shocked. And I would say from my experience of now 46 years of oncology nursing, this population is the most anxious, and they're the most likely to what I call bolt if you don't bring them in for a safe landing as quickly as you can. Patients obviously can feel lost in the system, and as we know, regulatory and accrediting entities are requiring navigation and survivorship care planning as a part of our accreditation process. So I wanted to look at our current state. And I have to say that this isn't going to be surprising to you, but it's kind of like 17 hands on the elephant's skin, if you will, when you look at what nurses that identified themselves as navigators. It was astonishing to me. There were 14 different titles. In other words, they were organizationally considered a navigator, but within that role, their role was very different. In other words, I don't consider a navigator's function really to be flushing portacas or scheduling, initial CT appointments, those kinds of things. Obviously, we all do that, but not the port flushes necessarily. But I wanted to look at how they perceive their roles. So we sent a survey to 68 reported navigators. We are a hospital-based and ambulatory-based system. And our questions were revolved around job description, what their challenges were, what kind of organizational structure, who they reported to. The nurse navigators in one breast health center report to a social worker. Some navigators report to the head of imaging. It was all over the place. Among all navigators, there was a wide variety of tasks, titles, staffing, and workload. And the biggest issue for our system we face, and I was talking to, I'm sorry, I don't know your name, in terms of the medical record issue and tracking, and all of our nurses are using different Excel spreadsheets. You all feel the pain, I'm sure. We need to really get better at how we are really tracking and what we're going to track. A little bit farther on in this presentation, I'll tell you that I learned very quickly, all of us have to be identifying what questions we want to ask and uniformly do that. So we're comparing apples to apples, so to speak. So as a result, I was asked to serve as a co-chair of an entire patient navigation committee. So that's looking at the Valley area, which is Sacramento, all the way down to Los Banos, which is called the Valley area, and the Bay Area, which is Palo Alto and Santa Cruz, all the way up to the northern coast of California, where Linda was a CEO. We actually are making a recommendation next month to the Patient Care Council that we want to actually recommend that any new nurse navigator hired into our system must possess a certification through the ONCC. The reason we decided to do that is there's a great country western song, if you will, that says you've got to stand for something or you'll fall for anything. So we decided that we wanted to stand with a professional practice model of looking at oncology, new nurse navigators coming in, possessing that baseline OCN, so to speak. We did a provider survey where we sent a survey to 98 of our oncology providers. We had a not so great a return in the sense it was 19% response rate. But what I thought was really interesting is the overall satisfaction with the navigators were high. 63% said they would like the navigator to be more involved at the initial diagnosis. And there was also lack of clarity, which was not surprising to me, about the navigator role based on the survey that we did of the navigators and the variability of their role. And that care coordination was seen as the most important. What keeps me up at night is really how our patients perceive our care and what it is that we can do. I co-facilitate with one of our young survivors a young women's support group, and a couple of years ago, I became very, pensive. It was very troubling to me because a young woman who was actually in a different healthcare system, all of our support groups are open to anyone in our community. She described to me she was nursing her 6-week-old twins, and she was home by herself with her toddler, her 2-year-old. And she told me she got the call that she had breast cancer. So I started to look at patients. I started to ask them where they were told their diagnosis. And I was actually very troubled by this. In our particular situation, in our breast centers, we have the nurse see the patient at the time of suspicious finding, help set up the biopsy, and then 3 days later, because we get a preliminary path back in 24 hours, we set that physical appointment for the patients to hear their diagnosis. The number of patients that were telling me that they were driving down the road, that they were shopping, they were in their kids' soccer fields was shocking to me. So we looked at a survey in terms of what patients preferred in terms of what their diagnostic, how they received their pathology results. We looked at a geographic area. We sent out a survey to 519 patients. Our return rate was 38%. So what patients told us was that they wanted to know results as soon as possible. And I think that this is the conundrum when the radiologist will say to me, well, I asked the patient how they wanted to know, and they said, just give me a call. And I said, but they don't really necessarily know what that call is going to be. We don't really know if they're driving. We don't really know if they're shopping. So let's really dig a little bit deeper. So we looked at the patients and we looked at what they were telling us what they wanted, and they wanted to know the results as soon as possible, but they wanted a personal touch, and they wanted information who they perceived was their expert, and they wanted to know next steps. One of the things that was touching to me in the survey was a patient said, don't tell me my diagnosis and then tell me I'll get more information by someone with whom I have a future appointment. Give me next steps. And I was very happy that Doris yesterday presented that the radiology, or commented that the radiologist was so wonderful in telling her diagnosis. I would submit to you that we've got to get better at how we're telling patients these words that will forever change their lives. The nurse navigator informing the patient were more likely to get what patients valued, which was the right amount of time, resources, emotional, educational support, more than other types of providers. That in-person, face-to-face allows them to say, I'll be able to actually say to them when I give them the binder and go over their pathology report, so I've set up an appointment for you to see the medical oncologist or the surgeon. We're getting your insurance approval for your MRI. Their next steps are clearly articulated. So the impact of nurse navigation. We started to look at our data in terms of how long it was taking. We knew that there was not a problem with someone coming back within 3 days for a call back for a diagnostic or getting somebody in for biopsy very quickly. What I was worried about was what was happening in terms of, most importantly, the time from hearing the pathology reports to their first medical oncology or surgical oncology consult. And so and these are calendar days, and oftentimes we're in a managed care situation, and many of our patients are Medi-Cal, so we have to get a RAF or a TAR to be able to have some of the patients seen sometimes. So I wasn't so much worried about the 7 days, which was actually about 5 days for the initial surgical consult. What I was worried about was the fact that the first medical oncology appointment was taking so long. So it was taking, so this was when I did a deeper dive, it was because the surgeon was the first point of referral. They would do the surgery, and then for patients on adjuvant therapy, then make the referral postoperatively. So there was a delay. So what we decided to do was we did a Kaizen and a lean, and we looked at the fact that if the nurse, when she gives the pathology results or actually notifies the PCP that the patient has a positive pathology diagnosis, we're able to actually recommend to the PCP that they put in those referrals right away so that they actually go in for the surgeon and the medical oncologist simultaneously. That really shortened the time. We also, when I presented this data, we also recognized the doctors were very happy with me because I said, you know, you need some reinforcements. So we were able to hire a third medical oncologist in this particular practice based on this data. Outmigration. How we defined outmigration is our analytic cases, so those patients that are diagnosed at our facility and then go somewhere else for care. And the variability was huge in our system. It's between 13 and 74% in our system. So I decided to look at what can we do about the outmigration. If you look at location B, that's where the nurse navigator becomes involved at the time of suspicious finding, and then the patient receives their pathology results within 3 days after their biopsy. When you look at location A, they have an outmigration rate of 74%. So out of the 425 new breast cancer diagnoses that location A has, 74% of those patients were outmigrating. So when I say we need additional navigators, I had to quantify that. I had to look at that and say, when hospital administrators say to me, how do we afford navigators? My response to them now is, how do we not afford navigators? So we looked at a pilot, and I won't go through all this for time, but what's really interesting is this bottom factor where we looked at a pilot of patients, and we looked at what I want you to really look at is those patients who were in the pilot program but were told their breast cancer diagnosis by their PCP, the outmigration was 50%. Now, I will admit to you this is a very small sample size. What happened in the midst of this pilot was the one surgeon and the person that was leading this had a tremendous bike accident, so was out for about 4 months. So we're continuing that data when she comes back to work to explore this. But the patients who were in the pilot program and were given their diagnosis by the nurse navigator had a significant reduction in the outmigration. And I would support it's back to the personal experience that you have with that patient. So looking at this, again, we went from a 74% to a 50% to a 22% outmigration. I won't go into this again for time, but what I decided to do is to look at, I looked in 2014, 2015 for the first 6 months of therapy, and I looked at what we billed versus what we collected. And the loss was, if a patient left the system, was about $106,000 per patient. So I decided to reevaluate this, and Nick will be very proud of me, I think, because what I did was I had the financial people. I'm not a numbers person per se. They really got tired of me after a while with these emails. Well, what about this? Well, what about the J codes? Well, what about the CPT codes? Well, what if we look at Blue Cross? What if we look at the PPO? What do we look at that? I said, Cindy, information toxicity. So I wanted to quickly look at, and again, this is going to, please don't think so much about your specific numbers, but rather the questions. Sometimes answers beget questions and questions beget answers. So what I wanted to do is look at, if you just base it on revenue, because I said to one of the hospital administrators the other day, they said, Cindy, you have to care about our overhead costs. And I said, those are your fixed costs. You're going to be open anyway. How do we optimize your care? How do we make sure that we give the best, most timely care? So I looked at revenue, and I looked at if we collected, so I looked at HER2 positive, HER2 negative patients. I looked at 20 months of therapy, and I looked at what we billed versus what we collected. And on average, a very conservative estimate, because I didn't look at a lot of the downstream revenue. I didn't look at lots of other factors. So I'm pretty sure that I feel solid that this is a conservative number in the sense of if we're able to keep a patient in our system, our revenue will be $125,000 per patient. If you look at that with the contribution margin, which is what the financial people wanted me to look at, so back to the other one, if you keep 2 patients in the system, you more than pay for your navigator. So when you factor in outmigration and then you look at the factor relative to the return on investment, if you look at keeping a patient, 7 to 10 patients in the system. And I won't go through what was happening with the location where there were tremendous outmigration. Well, I will just give you one quick example. They had a very convoluted system where the pathologist was calling the PCP before they would sign out the final path. Then the PCP would notify the patient. Then the navigator would notify the patient after, or connect with the patient 4 days after the PCP, presumably. So those patients were gone. You know, we're in UCSF, Stanford, we've got lots of private organizations as well as universities. So we really had to look at what is the best care, most timely care, most personalized care in our system. So if you look at, for example, based on this revenue model, if you look at outmigration at 72%, the amount retained in the system versus if you look at outmigration at 16%, the amount retained within the system, which is again my argument of why I'm going to be going to administration and looking at all of our disease types and looking at how we can best prevent outmigration, but at the same time make sure that our care is timely and these patients are supported effectively through the entire care trajectory. I would submit to you that healthcare is in an environmental climate change. I was very aware of that when we're trying to reopen our infusion center, and I was aware with the impact in Puerto Rico that we've got an IV solution shortage. And I, again, through going through the fires and realizing what we faced, I think navigation now is we're going to require this tenderness and tenacity to continue the scientific inquiry, to look at our best practices, to look at how we develop, we implement, and most importantly, evaluate our programs. And I thank you for being here, and I would like to give our collective gratitude to those patients that we are so honored to serve.